Live from Boston, I'm Emilio Madrigal, and today is the 1st of May 2020, and I'm joined by my colleague Rifat Manan, who is based out of Philadelphia at UPenn. We hope everyone continues to stay healthy and practicing safe social distancing during this current pandemic that we're going through. Today, we are very happy to welcome Dr. Roberto Garcia, who's an associate professor of clinical pathology at the Hospital for Special Surgery in New York City. And Dr. Garcia will be presenting the first of a three-part bone and soft tissue series. And the first lecture is titled Bone Forming Tumors. As always, please feel free to post questions and comments in the Facebook and YouTube chat windows, and Rafat and I will make sure to pass those questions and comments to Dr. Garcia at the end of the lecture. So with that, I will now turn the microphone over to Dr. Garcia.
Thank you very much for the kind introduction, and good morning, everyone. Greetings from New York. Today is a very gray and rainy day in New York City, and it is a great pleasure to be here this morning. We're going to be discussing today bone-forming tumors. This is part one of a three-lecture series, and this is actually my disclosure slide, so there's nothing to disclose. And today we're going to be discussing bone-forming tumors, benign and malignant. We're going to be talking about bone cysts and also fibro-osseous lesions. On the next lecture, we'll be talking about benign and malignant cartilaginous tumors and chordoma. And on the third lecture, we'll be discussing miscellaneous bone tumors, giant cell lesions, and fibrous tumors, benign and malignant. So primary bone tumors are rare, and most of the neoplastic disease that we see in clinical practice are going to be metastatic carcinomas to the bone, and also myeloma. But primary bone tumors per se are rare, and that's one of the reasons why people have very little exposure to them. And of course, a little bit of fear about dealing with them. But actually, it is a very fun field, and most of these tumors are challenging, and that's what makes it amusing. And there is kind of like a guessing game, where we have to significantly establish good clinical and radiological correlation. So a lot of information that we get prior to looking at a slide on a bone specimen or biopsy is very important, and actually helps us to establish or narrow down our differential diagnosis with a certain degree of accuracy. So the clinical history is very important. It is important to know whether the patient has any prior history of malignancy or a particular neoplastic disease, and of course certain conditions that predispose to bone tumors. One of them might be, for example, Paget's disease or osteomyelitis, chronic osteomyelitis, which can predispose to the development of osteosarcoma. The patient's age is important because bone tumors have predilection for certain age groups. The great majority of them will occur in the ages of active growth. So children and adolescents are more commonly going to have the great majority of bone tumors, benign and malignant. But other tumors are more prone to occur in older age, like chondrosarcoma, for example, which is usually a tumor that is seen in the 40s and 50s and beyond. That doesn't mean that they cannot make exceptions to the rule, but more or less we can more or less say this particular tumor will be unlikely given the age of the patient. Presence of pain and palpable mass, actually these are some of the more important manifestations of bone tumors. Pain means basically that the tumor is actively growing. A lot of tumors are completely asymptomatic, so discovered incidentally when an X-ray is taken for another instance of, for example, trauma or looking for something else, and then they incidentally find tumors. But it is important to determine whether there is presence of pain, the intensity of the pain, and whether there is a pattern to it. Because certain tumors have a peculiar pattern of pain, which may be nocturnal. And also, it's important to know if there is a response or improvement by the use of non-steroidal anti-inflammatory drugs or aspirin. And of course, if there's a palpable mass, it is important to determine how long has it been there. Has it grown recently? Has it grown rapidly or slowly? Sometimes the patients tell us that the mass has been there for years, or sometimes they tell us that it appeared yesterday. And that a lot of times is not reliable. But we more or less put together all the pieces of information that we have in order to narrow down our diagnosis. Tumor location, paramount, extremely important, because tumors have a predilection for certain locations, even though, again, there are exceptions to the rule. Very few tumors will occur in the epiphyseal portion of the bone, like chondroblastoma and giant cell tumor. The great majority of them will be concentrated around the metaphysis, which is the area of more active growth. It's right above the epiphyseal growth plate. So this is the area where most chondromas, osteosarcomas, chondrosarcomas, aneurysmal bone cysts, etc., a lot of the tumors will occur in this area. And other tumors will have predilection for the diaphyseal portion of the bone. Is the lesion intramedullary, or is it cortical based, or is it rising on the surface of the bone? So all of these are things that we need to know in order to establish our diagnosis. And then when we get to the part of the histological examination, that is almost like the last thing that we need to confirm our suspicion. The imaging characteristics of the lesion are extremely important, and that's the part where some people don't feel comfortable with, because in order to be a good bone and soft tissue pathologist, you have to establish radiological correlation or imaging correlation, and you have to actually look at the x-rays. I particularly recommend that some people conform to looking at a radiological report. That is a very bad practice, because you're reading somebody else's interpretation. You have to learn how to make your own interpretation of the tumor. And there's nothing better as looking at the plain film. The plain film continues to be, and will continue to be, the gold standard for the evaluation of bone tumors. This is like the gross picture of the tumor, because you're not going to be able to see it. The lesion is not on the skin. So with an x-ray, you're going to be able to look at a lesion that will be basically on the cortex or intramedullary. Is the lesion producing some degree of reaction in the surrounding bone, meaning sclerosis or even periosteal reaction or new bone formation on the surface of the bone associated to where the lesion is standing? Is the outline of the lesion well circumscribed? It has a sharp margin, or is the margin diffuse and ill-defined? What are the internal characteristics of the tumor? It is lytic, but does it have any type of trabeculeations within it, or is it just completely lytic? Is it showing any type of aggressive behavior, like disrupting the cortex or maybe eliciting periosteal reaction? Again, location of the tumor, metaphysis, probably metadiaphysis, diaphysis, or involving both the epiphysis and the metaphysis. So all of these pieces of information immediately begin to bring out differential diagnoses. Is this giant cell tumor? Is this an osteoid? Is this an osteoblastoma? Is this a chondromyxoid fibroma? So also it is important to see what the status of the growth plate is. This is an individual who is young. The growth plates are still open. It is an actively growing individual versus somebody where the growth plates are completely closed already. So this is a skeletally mature patient. So some lesions are more common in skeletally mature patients, and others are more common in skeletally immature patients. Is the lesion disrupting the cortex and invading into the soft tissue? That is something that sometimes is not as easy to see on the x-ray, but is something that we need to see. So that is definitely a feature of aggressiveness. This has to be a malignant tumor, not a benign one. And whether the tumor is producing any type of matrix, we can see that it's destroying the bone. It has a very ill-defined or irregular margin, and if there's some evidence of sclerosis in here, so that means that the tumor is mineralizing, is making some kind of matrix. This one in particular is not making any type of matrix, but definitely has a very destructive pattern, and actually there's a pathological fracture associated to it. So these are features of malignancy versus benign lesions, which actually, by the way, another thing that we need to see in the outline is whether there's perilesional sclerosis. You see that line, the white line around them, that is sclerosis. It means that the bone surrounding the lesion has enough time to react and try to reinforce in order to prevent the progression of the lesion somehow. So that is something that we It's indicative of a benign condition. Other things that we need to see in the X-ray is the type of mineralization that the tumor is showing. Is it, like in this case, sort of like flocculent or stippled calcification with some rings and arcs? This is characteristic of a cartilaginous lesion. Now, is the lesion circumscribed and not making anything or doing anything to the cortex versus another lesion which is actually extensive? It goes from here to here. It has stippled calcification with a little bit of a ring and an arc here. And you see how the cortex is getting endosteal scalloping, meaning that there's something is going on with the cortex between the tumor and the cortex, meaning that this is an aggressive feature. So this is most commonly seen in a benign condition. This is suggestive of at least low-grade malignancy. In this particular case, this is an enchondroma. This is a low-grade chondrosarcoma. Now, the pattern of mineralization can be very diffuse and dense, like we see here. This is most likely bone formation versus cartilage formation. And we can see an insinuation of the cortex being permeated, and maybe the tumor has like a little shadow outside. So that means that it's probably invasion into the soft tissue. This is an osteosarcoma in this particular case. Patterns of periosteal reaction are important. Some of them are interrupted and elevated, like we see here, just a little a bit of a Cotman's triangle, but sometimes we see lamellated type of continuous periosteal reaction. This is an onion skin pattern of periosteal reaction. Periosteal reactions are usually seen in aggressive lesions, but not necessarily mean malignancy. For example, osteomyelitis can produce a similar pattern. So everything has to be taken in the appropriate context. And then, fortunately, we're still going to be needed in order to establish a histological diagnosis. Some lesions arise in the surface of the bone, so it is important to see where is the lesion located and whether there is a continuity between the lesion and the medullary cavity. This is something that is very characteristic of a lesion, benign lesion of bone, which is very common. It's an osteochondroma, and it has basically a cartilaginous gap that it covers the surface, but there's continuity of the cortex and the medullary cavity of the host bone and the lesion. And finally, we have another lesion that arises on the surface of the bone with a very peculiar location, which is the posterior aspect of the distal femur, where we can see that the cortex is actually intact. So this is a surface lesion. It's growing on the surface of the bone with no communication between the lesion and the medullary cavity of the bone. So all of these are things that help us at least pre-establish our diagnostic differential. And then the histology is what comes next. CT, MRI, bone scan. These are all adjuvant to X-rays. So I am very disappointed when I receive a bone biopsy with an MRI, and that's it. Because nowadays we tend to jump for the most modern techniques and the ones that are more readily available, or perhaps the ones that we think that might be more accurate in establishing a diagnosis. And a lot of times we get MRI, we get a bone scan, but we don't get in a plain film. And many times I insist and try to obtain that plain film, because I get a lot more information about the way what the lesion looks like from an actual X-ray than from an MRI. The MRI is helpful to see how much the lesion extends or occupies within the medullary cavity, and is absolutely outstanding for the evaluation of soft tissue planes. And soft tissue lesions, by the way, MRI is actually the gold standard for evaluation of soft tissue lesions, even though plain films can be helpful in soft tissue. Also, we can obtain information about certain characteristics of the tumor. For example, this is a tumor that is occurring in the proximal humerus. We can see that it is partially calcified. It is in the metaphysis, almost close to the epiphysis of a long bone, and it has a very peculiar pattern of calcification with a little bit of rings that we can see here. So this is definitely a cartilaginous lesion. It is unclear whether the lesion is permeating the cortex, even though it looks like it's probably a little bit thinner on this side, and we can see that on fluid sensitive sequences is bright, so, and it's dark on what we call T1. So this tells us that there's a lot of water content within the matrix of the lesion. It could be fluid, but it also could be cartilage because cartilage, the extracellular matrix of cartilage contains a lot of water. So those are the things that MRI, CT help us also look at the lesion in different planes. For example, it's not only AP and lateral, but we can actually see axial, sagittal, and all these other planes in order to establish the extent of the lesion and the status of the cortex. These are all adjuvant to plain film. So I just want to remind you about that. And also bone scan is help us to see basically whether the lesions are actively producing bone or there's a significant osteoblastic activity or bone turnover, and also if there is vascularity. So bone scan will be had when there is high vascularity or there is active bone turnover. This is actually non-specific. Osteomyelitis can be active or had on bone scan, but also malignant tumors in general tend to be had on bone scan. So it is very specific, it's very sensitive, but completely non-specific. Okay, so let's go and review bone tumors per se. The first one is osteoma, which is basically an abnormal, dense mass of bone, usually polypoid, that occurs almost exclusively in the bones of the skull. They can occur in the paranasal sinuses or the orbit, or on the surface of the bone. These are lesions of adult life. Most of them are seen in the 4th and 5th decades, usually asymptomatic because they grow very slowly and often discovered incidentally. Interestingly, osteomas, when they're multiple and often when they're discovered at a young age, they're associated to Gardner syndrome, where osteomas are seen combined with epidermal cysts, fibromatosis, and colonic adenomatous polyposis. So these patients have a familial adenomatous polyposis. And the lesions have been classified because of their location. The surface ones have been called parosteal or ivory osteomas, and the ones that occur in the paranasal sinuses are called sino-orbital osteomas. They're very dense because they're made of compact bone, so they're going to be very similar in density to the cortex of the surrounding cortices. When they occur within the paranasal sinuses, because they have a very slow growth, they almost adopt the shape of the sinus where they are dwelling within. And of course, in this particular instance, they can produce obstruction of the paranasal sinus with accumulation of secretions, infection, and chronic sinusitis, in which instance they need to be removed. The histology of an osteoma is exactly as cortical bone. It's basically compact lamellar bone with only haversian spaces, but sometimes they can have also a trabeculated appearance. And the osteocytes are within lacunae with very pyknotic, hyperchromatic nuclei. They can be composed of pure compact bone or have a mixture of compact lamellar and woven bone, and there can be also cancellous or trabeculated components, which may be sometimes confused with other tumors like osteoblastoma. Surgical excision for osteomas is only indicated when there are symptoms, like in chronic sinusitis, like I mentioned before, and their recurrence is extremely rare. No malignant transformation has ever been reported on an osteoma. There is an intramedullary counterpart to an osteoma, which is known as bone island or inostosis. These again are lesions that are small and they are clinically indolent. They tend to grow very slowly, so often discovered incidentally. And they appear as an intramedullary density that usually has a kind of like a spiky or a thorny appearance. That is because the central dense bone is made of cortical type bone or compact bone, but you can see at the periphery how the edges of the lesion kind of merge or fuse with the surrounding trabecular bone, imparting this kind of a spiky appearance. And then if you go on higher power, you will see that it's essentially compact dense bone with haversian spaces. Bone islands sometimes can be confused with a sclerotic metastasis, and that will be something that you would like to rule out. Bone islands are cold on bone scan versus, let's say, a metastatic prostatic carcinoma or breast carcinoma that produces a lot of sclerosis. That will be an osteoblastic metastasis. Those will be had on bone scan. So bone scan will be helpful in this particular instance. But again, remember this is completely non-specific. Now, a lesion that makes woven bone, not lamellar bone, or not a mature compact bone, is known as an osteoid osteoma. These are very small, usually less than 2 centimeters in size. Some experts prefer to use the 1.5 cm cutoff point. But essentially, these are small circumscribed lesions that are osteoblastic in nature. They produce woven bone, and this is something to remember. Most of the bone that is produced by neoplasms is woven. With a few exceptions, but they can be sometimes a mixture of woven and lamellar. And these lesions tend to occur mostly in the cortices of the long bones, but they can occur practically everywhere. Very rare in the craniofacial bones, and radiographically they're characterized by a small area of lucency surrounded by reactive sclerosis, and sometimes there can be significant periosteal reaction. Many times you will see a central area of density, which is what we refer to as the nidus. When seen on X-ray and CT, they have this sort of targetoid appearance because you see the central sclerosis of the nidus surrounded by a lucent halo, and then all of the surrounding sclerotic bone that is seen around the lesion imparts that so-called targetoid appearance. Now, one characteristic feature about osteoblastoma is that there is a sharp pain that is worse at night and is dramatically relieved by the use of non-steroidal anti-inflammatory drugs. And that is very helpful in the history. And if you combine this particular presentation with an image like this, you don't practically do not need a diagnostic biopsy. But many times it is necessary because these lesions can be sometimes confused, or actually the differential diagnosis includes a Brody abscess, for example, which can look similar to this. The bone scan can be quite sensitive to detect an osteoblastoma, to the point that sometimes the patients may present with all the signs and symptoms of osteoblastoma, but the X-ray really doesn't show it. Like, for example, in a lesion like this, where there's so much sclerosis around it that you may not even see. There's basically an insinuation of a shadow here of where the osteoblastoma is. So sometimes the CT and bone scan are very sensitive in detecting the presence of the nidus. So osteoblastoma is a lesion of young individuals. They're usually seen in the first and second decades of life, actually the second and third decades of life. But children and adolescents are more commonly affected. Males are twice as commonly affected than females, and the most common location include femur, tibia, humerus. They can occur in the spine, usually involving the posterior elements of the spine rather than the vertebral body. And sometimes they may be intra-articular, mimicking monoarticular inflammatory arthritis. And to make matters worse, they induce a kind of inflammatory synovitis that sometimes can be confused with sort of like a rheumatoid process. In the spine, they may lead to painful scoliosis and muscle contractures in the surrounding area. And like I mentioned before, sometimes on X-rays, they're not very clear. So you will require an adjuvant like CT in order to demonstrate. Like, for example, this is probably invisible on a plain film on the spine because of all the interposition of all the bones and soft tissues. But on an axial view, we can clearly see the nidus with a targetoid appearance, a central sclerosis surrounded by a lucent halo, and again, at the periphery, we have all these reactive sclerosis that are induced by the tumor. In the times when the lesions used to be resected, like in this particular resection specimen, they have this very well circumscribed appearance of red-brown gritty tissue. But nobody resects osteoblastomas like this anymore. This one in particular is a juxtaarticular osteoblastoma. We can see that the outline of the lesion is remarkably circumscribed. It's very sharp, and it does not really permeate into the surrounding bone. The lesion is composed of interlacing irregular trabeculi of woven bone in a very vascular stroma. We're going to see this more closely now. So here we see the nidus of the osteoblastoma has all these very irregular trabeculi of woven bone, and you can see the cellularity of that woven bone is a little bit higher than the conventional trabeculum, but most of the osteocytes within the lacuna are very small. And the stroma is fibrovascular. There's spindle cells and a lot of blood vessels, and there's no significant cytological atypia. Mitosis can be seen, but they're never atypical. Osteoblastic lining of the around the trabecula is common, and occasionally you see scattered variable numbers of osteoclast-type giant cells. This summarizes the histology of the nidus of an osteoblastoma. Why are these lesions painful? Well, there are several theories, but there's a lot of prostaglandin E2 production within the nidus of an osteoblastoma, which is what explains their dramatic response to aspirin and other nonsteroidal anti-inflammatory drugs. Recently, FOS and FOSB mutations have been detected in osteoblastoma, and like I mentioned before, the differential diagnosis includes osteomyelitis proteapsis. Osteoblastoma is a big brother to osteoblastoma. It has exactly the same histology, but it's larger, and we're going to review it next. And of course, Ewing sarcoma sometimes can be confused with an osteoblastoma, because, especially the ones that have a very prominent periosteal reaction. Sometimes that can be seen, but of course, this is a small round blue cell tumor. So we still need to confirm the diagnosis of osteoblastoma. These lesions have limited growth potentials, so they remain the same size for years and may rarely regress spontaneously. Complete removal, usually by curettage or resection, is the treatment of choice, but nowadays it is more popular to ablate them with radiofrequency or thermocoagulation, which basically they insert the probe into the lesion and they thermocoagulate it. The main problem with this technique, which is very safe, effective, and leads to a quick recovery, is that there is very little tissue for diagnostic confirmation. Usually the interventional radiologist will take out a core of the tissue and send it to the pathologist and then thermocoagulate the lesion. So it is sometimes we're fortunate to see within the core there's the tip of the nidus. So this is what the only disadvantage to this technique, but it's very effective. So to summarize, the histology of the nidus of an osteoblastoma are interconnecting trabecula of woven bone in a bland fibrovascular stroma with osteoblastic lining and variable numbers of osteoclast-type giant cells or osteoclasts. Osteoblastoma is similar to an osteoblastoma, almost identical or indistinguishable from it, but it's larger size, usually larger than 2 cm. The great majority are 3, 4, 5 cm, so it is not a problem when we establish a radiological correlation. The pain that is seen in osteoblastoma is usually dull, not as intense, or really not with a nocturnal pattern, and it not necessarily will be relieved by the use of aspirin. The presence of perilesional sclerosis may be there, but not as intense as you would see in an osteoblastoma, and sometimes it's not present at all. And this tumor has a predilection for the axial skeleton, usually the posterior elements of the vertebrae, but may also be seen in the long bones. Most of the times, these lesions are intramedullary, in contrast to osteoblastomas that tend to be more cortical-based. And secondary aneurysmal bone cyst is often seen in osteoblastoma. And sometimes in a biopsy, we need to be careful because if we see ABC, that is actually a secondary phenomenon, and we have to watch for the presence of pre-existing condition. Osteoblastoma has a predilection for the axial skeleton. This is one of the characteristic features of it, but it can be seen on practically any bone, has the same age and gender distribution as osteoblastoma, and of course, the differential diagnosis can be established based on the size and the pattern of the pain. Osteosarcoma will be a lot more challenging, but of course, this is a lesion that will have obvious evidence of features of malignancy on the histological appearance, and of course, the radiographic appearance will be that of a more aggressive lesion. The treatment of osteoblastoma is also excision or curettage, and recurrences may occur in up to 25% of the cases. Very rare cases of malignant transformation of an osteoblastoma have been reported. This is an osteoblastoma of the spine. We can see that it's not as small and targetoid like the osteosarcoma that I showed you before. It's very well circumscribed, but it has a variable pattern of sclerosis, and in some areas it's a little bit lytic as well. The posterior elements are commonly involved. Very rarely you will see it in the vertebral body. And osteoblastomas can occur also in the craniofacial bones. In the mandible, for example, they have a predilection for the mandible where they can occur as a lytic lesion with an irregular pattern of sclerosis, maybe involving the adjacent root of the surrounding teeth. And histologically, osteoblastoma will have essentially the same pattern of woven bone trabeculi in a fibrovascular stroma that we see in osteoblastoma. Perhaps there might be a more prominent lining by osteoblasts in osteoblastoma than in osteoblastoma, but that is something that I probably wouldn't take as an absolute criterion to distinguish one from the other. Again, we need to correlate the clinical information and the radiological imaging in order to determine whether it is an osteoblastoma or an osteoblastoma. Osteoblastomas, in the differential with osteosarcoma, osteoblastomas have very sharp circumscription, and they will, even if they're shelled out, they would have a very sharp margin. You can see all of this is the woven bone of the tumor, and we can see how even in this at this periphery, we can see a very sharp margin around it, and they never will permeate into the surrounding bone. Like in this particular case, where we can see there is like an advancing edge of the tumor pressing against the surrounding lamellar bone, and sometimes at the edge of the lesion, you will see that the pre-existing bone is being entrapped within the lesion. All of the small ribbons of woven bone that are seen here are from the tumor. This is pre-existing cancellous bone that is entrapped within the lesion. So permeative growth is a feature of osteosarcoma, not of osteoblastoma. And this is how we can establish the diagnosis together with, of course, clinical and radiological correlation. Now, some osteoblastomas can show aggressive behavior. They can be locally aggressive. They can be large, usually about 5, 6, 7 centimeters in size, and they can also show evidence of destructive pattern or sometimes recur locally multiple times. And aggressive behavior has been correlated with the presence or the histological feature of epithelioid morphology in osteoblasts. This is in the form of osteoblasts with abundant amphiphilic to slightly eosinophilic cytoplasm with well-demarcated cell borders that impart this epithelial-like appearance, and they form sheets in between the trabecula. They not only remain lining the trabecula like I showed you before, but you can see that the entire space is occupied by all these epithelioid osteoblasts. And you can see a little bit of woven bone formation in it, which in a biopsy may be worrisome for something more aggressive like an osteosarcoma. But if you stand back, look at the whole picture, you will see that it is most compatible with an osteoblastoma. So, epithelioid osteoblastoma and aggressive osteoblastoma have been used interchangeably, but many authors believe that epithelioid histomorphology doesn't necessarily mean aggressive behavior. There have been classic osteoblastomas that show aggressive behavior, and there have been epithelioid osteoblastomas that behave like a conventional osteoblastoma. So, even though in some publications you will see that they are used as a synonym, that doesn't necessarily have to be true. Osteoblastomas have also shown FOS and FOSB mutations, which shows the correlation, or actually the relationship between osteoblastoma and osteoblastoma. And again, this is something we should not forget: the pattern of irregular interlacing trabecular woven bone in a fibrovascular stroma with prominent osteoblastic lining and scattered osteoclasts. Now, in the malignant bone forming category, we're talking about osteosarcoma. And osteosarcoma, by definition, is a malignant mesenchymal neoplasm where bony matrix is being produced and is mostly in the form of woven bone, or commonly referred to as osteoid. Osteosarcoma is the most common primary bone malignancy. It comprises about 20% of all bone malignancies, and The great majority, 80 to 90% of them, are the conventional high-grade intramedullary. This is actually one of the easiest to diagnose, so that is fortunate for us as well as for the patients. But there are a lot of different variants that are not as common and sometimes can be quite challenging, and those are the ones that like to come out in board exams and in service examinations. So 4% of them will be of the telangiectatic type. This is a type of osteosarcoma that has a lot of dilated vascular-like spaces filled with blood. Small cell osteosarcoma is comprises about 1 to 3% of the cases, and the cells approximate the morphology of Ewing sarcoma or lymphoma, but there is active woven bone production by the tumor cells. There is an intraosseous, well-differentiated osteosarcoma or low-grade central osteosarcoma, about 1 to 2%, which has a relatively indolent behavior. And there are all of these, which are the juxtacortical ones, the ones that occur on the surface of the bone. There is a low-grade version, of well-differentiated version of that, which is known as parosteal osteosarcoma. There's another one that is called as surface chondroblastic osteosarcoma, which is referred commonly as a periosteal osteosarcoma. High-grade surface osteosarcoma is exactly the same histomorphology as the intramedullary one, but the tumor remains on the surface with little or no invasion of the medullary cavity. And this is a very extremely rare form, which is known as intracortical osteosarcoma, which we're not going to discuss in this lecture. Other rare histomorphological variants include all of these type of osteosarcomas. Fortunately, you don't have to deal with that. That is so it's very rare conference type cases. What is important to report in a biopsy from osteosarcoma is whether the lesion is osteoblastic, chondroblastic, or fibroblastic, depending on the most prominent matrix that is being produced. Osteoblastic osteosarcomas comprise of up to 80% of the cases. The chondroblastic ones is when there's a significant amount of cartilage production, but there has to be woven bone formation in the tumor, and the fibroblastic ones are composed mainly of spindle cells and a lot of collagen, but also they have to have collagen formation. This is the appearance of a classic osteoblastic osteosarcoma. The tumor cells have this pear-shaped or polygonal appearance with eccentric nuclei and abundant basophilic to amphiphilic cytoplasm. And then usually you see the cells intimately associated to the production of this pink matrix in a very irregular fashion. This is a lace-like pattern of woven bone formation, which is a histological hallmark of osteosarcoma. Of course, the cells will have features of malignancy, which will be high NC ratio, vesicular nuclei, prominent nucleoli, mitotic activity. Often we see atypical mitosis. Chondroblastic osteosarcoma will have a lot of cartilage matrix. It is estimated that tumors that have more than 30% chondroid matrix production should be classified as chondroblastic osteosarcoma, but you have to have bone production by the tumor cells as well. So that is what distinguishes it from a chondrosarcoma, where there should be no bone formation. Chondroblastic cartilage tumors in general have a less than optimal response or no response whatsoever to chemotherapy. So that is what is important to determine if this such type is present, because the response to the therapy would be suboptimal. And finally, the fibroblastic osteosarcomas, they look like a fibrosarcoma or maybe an undifferentiated pleomorphic sarcoma. The cells tend to be predominantly spindle with obvious features of malignancy. Here's an atypical mitosis right here. There's a lot of collagen matrix in the background, but you definitely have to find an area of woven bone formation by the tumor cells, which is what it identifies as this lesion as an osteosarcoma. So you can have a combination of all of these patterns, including some of the small cells and also the giant cell rich components into the same tumor, or you can have one particular pattern predominate within the lesion. So, but it is important definitely to say whether it's chondroblastic, osteoblastic, or fibroblastic, because the response to treatment and the prognosis will depend on that. Osteosarcomas can be seen secondary to other pre-existing conditions. I mentioned that before: Paget disease, bone infarct, radiation, chronic osteomyelitis, and fibrous dysplasia are among the most common lesions that can predispose for the occurrence of osteosarcoma. Osteosarcoma has also been reported in association to orthopedic prosthesis and hardware, which is a very rare phenomenon, but it does occur. Patients with hereditary retinoblastoma have a very high predisposition for the occurrence of osteosarcoma, as do patients that have Lee-Fraumeni syndrome. All the syndromes that have been known to be associated to osteosarcoma include Rothmund-Thomson, Bloom, and Werner syndromes. Osteosarcomas are lesions of, again, areas of rapid growth and age of rapid growth. So the second and third decades of life are the where most lesions occur, and usually they do occur in areas of rapid growth like the distal femur and proximal tibia. The knee is an area where there's a lot of active growth during adolescence, and that's where most of the osteosarcomas occur. They can also occur in the proximal humerus, bones of the skull. Actually, the axial skeleton can also be involved. The pelvis, osteosarcoma has been described in every bone of the body, and also they can be extraskeletal. There is almost twice as more common in males than in females, and like we mentioned before, secondary osteosarcomas, which occur on pre-existing conditions, do occur usually in patients that are older than 50. So that peak is not really demonstrated in this particular graph, but there is a little bit of an increased incidence in this area or an age range, and that is the so-called secondary osteosarcomas. Pain, swelling, and palpable mass are the most common presenting signs and symptoms. Pathological fractures do occur often. Alkaline phosphatase may be elevated, but it's totally non-specific, and lesions are very hard on bone scan, which again is non-specific, but also helpful. Here we have a classic example of an osteosarcoma in a patient who is skeletally immature. The growth plates are open, and you can see there is a lytic and sclerotic lesion that is occurring in the metaphysis of the distal femur. The lesion is breaking through the cortex and invading into the soft tissue, and we can see these very areas of density with new bone formation. And there's probably a little bit of an elevation of the periosteum right here, which is referred to as Cotman's triangle. This is all the lesion has mixed lytic and sclerosis, and it is definitely fractured. So there is a pathological fracture, which is defined by a fracture that occurs in a bone that is affected by a pre-existing disease or condition. And here's one example of an osteosarcoma, and look how bright the tumor is. So are the growth plates, which are still open and active. So wherever there is a lot of bone turnover and osteoblastic activity, there will be activity or uptake by the bone scan. But the tumor is definitely showing significant uptake. Here's one example of an osteosarcoma of the proximal humerus. You can see it's a metaphyseal lesion. It's large. It's mixed lytic and sclerotic. It's invading into the soft tissue and elevating the periosteum proximally, which is known as a Cotman's triangle. And here's the gross appearance of that same tumor. They are quite heterogeneous. They have areas that look like cartilage, areas that look very bony, and some may even look a little fleshy. And here's the tumor invading outside of the bone into the soft tissue. So in X-ray, we cannot see really the extent of the soft tissue involvement, and that's where the MRI is helpful. The pattern of periosteal reaction of osteosarcoma is aggressive and characteristic, but not pathognomonic. There's definitely elevation of the periosteum proximally, where you can see where the tumor is actually coming out of the bone. This area here is sampled histologically will show this is the periosteum, which is being lifted from the cortex, and all of this new bone formation that we see here in a regular trabecula is periosteal new bone. So this is the Cotman's triangle. Here we see a little bit of the tumor that has come out of the medullary cavity into the soft tissue. So Cotman's triangle is a very characteristic, but not pathognomonic of osteosarcoma, because it can be seen in other conditions that are not necessarily malignant, like aneurysmal bone cyst. There are other patterns of aggressive periosteal reaction, like sunburst or hair on end, which can be seen all in osteosarcoma, but are not specific to it. And here is where we come into play. There are two things that are characteristic of an osteosarcoma from the histological standpoint. The first one is permeative growth. It means that the tumor is growing in so fast that it's invading all the medullary spaces without destroying or allowing for resorption of the trabecular bone. So you can see the bone trabecula are still there intact. Sometimes they would undergo necrosis, so you would see empty lacunae, but the entire space is occupied by a tumor. And this tumor, of course, is very cellular. It has some areas that look blue, others look pink. That means that the pink areas represent woven bone formation, the blue areas cartilage formation. So this is permeative growth characteristic of malignant tumors. Chondrosarcomas do exactly the same. You will see invasion of the medullary spaces and entrapment of the pre-existing bone. The bone will remain within the mass of tumor. And the second condition that you require for diagnosis of osteosarcoma is the formation of woven bone by the malignant tumor cells. And you can see how they are intimately associated with the tumor, with the cells. It is pink, so it looks like collagen, and actually bone is made of type 1 collagen. So one reassuring feature for confirming that something is really bone is when you see that it's becoming mineralized, because bone is the only one of the few type of matrices that naturally becomes mineralized. So seeing a little bit of purple, it doesn't hurt when we have a biopsy of an osteosarcoma. And this in particular will be a high-grade osteosarcoma, osteoblastic type. Here we see areas of woven bone formation by the tumor cells, areas of cartilage formation by the tumor cells. Look at the pre-existing trabecula, which is basically dead. There's no osteocytes within because the blood supply has been interrupted. And in many areas, you will see the more osteoblastic appearance of these bones, of these cells, which with eccentric nuclei, very abundant amphiphilic cytoplasm, and you may see even a lot of mitosis and atypical forms. But the condition that is required is to see woven bone formation, even if it is very focal, in a lace-like pattern. That is osteosarcoma. Some of them can look very pleomorphic, like an undifferentiated pleomorphic sarcoma. Others can have a multitude of osteoclast-type giant cells. This is a giant cell-rich osteosarcoma. Again, all of them require the formation of woven bone. And there is this very peculiar form of osteosarcoma, which is sclerosing osteosarcoma. It produces so much osteoid that it also does it in sheets. This osteoid will basically sort of like suffocate the tumor cells. They will remain entombed within lacunae and they shrink. This is a phenomenon that is known as normalization. And anyone would see this and say, I don't see the malignant features of the cells here. Well, that's exactly what happens. But no other condition will give you such a tremendous permeation and growth within the intertrabecular space, which is basically forming all these bony matrix other than an osteosarcoma. So this is a pattern of sclerosing osteosarcoma. To summarize, the diagnostic feature will be disorganized woven bone formation by malignant tumor cells in a lace-like pattern. It equals osteosarcoma. Chondroblastic osteosarcomas have abundant cartilage. This is something that we mentioned before, but there has to be woven bone formation. So sampling is important, and so is radiological correlation, because you will be able to see that the tumor has all of the characteristic features of an osteosarcoma on the X-ray. And you will not call up something a chondrosarcoma in a patient that is 15 years old. It doesn't mean that it doesn't occur, but it's really unlikely because we know chondrosarcomas are more common in older age groups. Fibroblastic osteosarcomas can sometimes be difficult to diagnose because they can look like a fibrosarcoma or like an undifferentiated pleomorphic sarcoma. And to make it worse, the finding osteoid or woven bone formation by the tumor cells is sometimes hard. So you have to sample the tumor extensively, because these tumors a lot of times do not show significant evidence of mineralization on an X-ray or within the lesion. But fortunately, most of the times this is found mixed with other more osteoblastic patterns. One main differential diagnosis for osteosarcoma is fracture callus. Fracture calluses can be quite cellular and atypical and very scary. if you look at them on high power, without establishing clinical and radiological correlation. And not very often we receive consults of cases that come from general surgical pathology departments where they say, oh, well, please rule out osteosarcoma. One of the things that for us is very helpful is to see there's a certain purposeful arrangement of the bone is in a very like a pre-trabecular type of pattern. It's trying to form some trabeculi, and you can see that there is also a very cellular cartilage that is being replaced by woven bone. This is endochondral ossification. So this is a phenomenon that occurs in a fractured callus, which is composed with the same components of an osteosarcoma: fibrous tissue, cellular cartilage, and cellular woven bone. But at least you can see that even though it can be quite cellular and atypical, there should be no atypical mitosis, and the trabecula, or the bone actually, is being formed in a trabecular type of pattern with very conspicuous osteoblastic lining or rimming of those trabecula. So that is very helpful to distinguish it from an osteosarcoma. But again, if you look, first thing you do is look at it on high power, you probably will be misled. There's no immunohistochemistry that helps us in diagnosing osteosarcoma. They are totally non-specific. They may be positive. They are positive for vimentin, maybe focally positive for S100. SADB2 is one osteoblastic marker that it is very useful when we are trying to confirm that the osteoblastic nature of the cells, but it's totally non-specific because we have seen a lot of other lesions that are not osteosarcoma that are SADB2 positive, but it's still useful. And basically, there's nothing specific in terms of chromosomal and genetic aberrations seen in osteosarcoma. As we mentioned before, the differential diagnosis with the fractured callus it can be quite challenging. It always requires careful clinical and radiological correlation. Undifferentiated pleomorphic sarcoma, or MFH of bone, is very rare, but it does occur. And when it does, it may have focal bone formation, which is usually metaplastic, or sometimes it is part of a pathological fracture. So we have to be very careful before we call something osteosarcoma when it could be possibly a primary undifferentiated pleomorphic sarcoma of bone. And the differentiated chondrosarcoma can have an osteosarcoma, so the differentiated component, but that usually occurs in patients of older age. Usually the transition between the cartilaginous component and the differentiated component is very sharp, and that can be seen grossly as well as radiographically. And chondrosarcomas in general, including this subtype, are positive for IDH1 and 2 mutations, which can be used as a last resort in very difficult cases. Osteosarcoma metastasizes via bloodstream to lungs and other bones. And the treatment is basically preoperative chemotherapy with limb-sparing surgery whenever possible. In the past, osteosarcomas were treated with amputation, and the 5-year survival was only 10 to 20%. That usually because these tumors were already metastatic. So regardless of whether you amputated it or not, the patient would die. But now, with the neoadjuvant chemo that is given before surgery, the tumor can be shrunk, so it can be resected completely, and usually the metastases also respond to the chemotherapy. And the survival rates, the cure rates have been reported to be up to 65 to 70% nowadays. And the role of the pathologist after diagnosing or confirming the diagnosis on biopsy is now to determine the chemotherapy effect or the degree of tumor necrosis that is seen in the lesion. What we do is we do a mapping of the tumor, where we can basically take a slab of the section of the lesion, and then we cut multiple sections of the block and map the entire tumor. We can do that on a specimen picture or sometimes on a radiograph, but it is important to determine your blocks, or actually mark down your blocks, so you know where each lesion, where each block or each section is coming from, and you can actually match them and correlate which one is coming from the soft tissue component, which one is coming from the central component, which one is where the tumor appears to be breaking through the cortex. So all of these things are helpful. And the histological response will basically look like this. Basically, you see that the tumor cells disappear, and everything in the background looks like a very collagenized or maybe acellular myxoid appearance with some inflammatory cells and actually no viable tumor cells. Or sometimes you can see the ghost of the tumor cells. So 90% necrosis is what is expected in a good chemotherapy response for an osteosarcoma. We're running out of time, so I'm just gonna go over the special types of osteosarcoma. We're not gonna be able to complete everything that we were planning to do today, but we can continue next time. So the special types of osteosarcoma include the well-differentiated or low-grade intramedullary osteosarcoma. This osteosarcoma tends to occur at a little older age. Usually the third decade of life is the peak incidence. The tumors usually involve the metaphysis or can involve also the diaphysis, and they tend to be frankly sclerotic or sometimes mixed lytic and sclerotic, but they don't really show very aggressive features. Periosteal reaction is not commonly seen or cortical breakthrough, and the margins tend to be ill-defined. Now, the lesion has a sort of fibro-osseous appearance. Usually there is irregular trabeculi of woven bone. These are sometimes very coarse and thick. And the stroma is moderately cellular and cytologically bland with very focal, mild or to moderate nuclear atypia. That is a characteristic feature of a well-differentiated osteosarcoma, and it has to be distinguished from fibrous dysplasia. There is a surface or juxtacortical counterpart to low-grade osteosarcoma, which is a paraosteal osteosarcoma. This tumor has a tremendous predilection to the posterior distal femur, and most of the times it arises on the surface of the bone with no involvement of the medullary cavity, or sometimes very focal. It is allowed for some degree of involvement, but usually not prominent. And the tumor has exactly the same histomorphology as the low-grade central osteosarcoma. It's irregular streamers of woven bone, which can also be lamellar in some areas, as you can see here. And there's a very moderately cellular fibrostroma with mild focal nuclear atypia. Parosteal osteosarcomas can have a little bit of a cartilaginous cap on the surface, which can be sometimes confused with the cartilaginous cap that is seen in an osteochondroma. But you never will see this type of stroma in the medullary component of an osteochondroma. And again, osteochondroma has a continuity with the medullary cavity, which parosteal osteosarcoma doesn't have. And here we see a high power view of the stroma with cytological atypia. Now, this is a beautiful example of a parosteal osteosarcoma arising in distal humerus. So they can occur in other bones as well. So there's something that is common to both parosteal and intramedullary low-grade osteosarcoma. They are low-grade tumors. They have excellent prognosis. They don't require chemotherapy. They have amplification of 12q1315, which is essentially the segment, the long arm of chromosome 12, where these two genes reside, MDM2 and CDK4. So by immunohistochemistry, you can detect focal positivity of the nuclei for MDM2, a more diffuse, kind of blotchy pattern for CDK4. But on FISH, you will see that there is amplification of MDM2. MDM2 normally should be like this red signal over here. And basically what we see is multiple red signals, numerous red signals within one single cell. That is actual amplification of MDM2, and that is essentially diagnostic for low-grade osteosarcoma. It is important to remember that MDM2 can be amplified also in well-differentiated liposarcoma as well as in dedifferentiated liposarcoma. So these amplifications of 12q1315 can be seen in a karyotype as giant marker chromosomes or ring supernumerary ring chromosomes that basically are composed of repeated sequences of 12q1315. And the main problem with these lesions is as good prognosis as they have, they may differentiate and then turn into high-grade sarcoma and then acquire metastatic potential. They will require chemotherapy treatment. This is one example of a paroxial osteosarcoma. This section is taken from here, where there's a classic appearance of a low-grade osteosarcoma, but then there is a significant intramedullary component that looks fleshy and has the appearance of an undifferentiated pleomorphic sarcoma. Both components will express the amplification of MDM2. So sometimes, if you get a biopsy only from a dedifferentiated component, if it is MDM2 amplified, it means that it is a transformation from a pre-existing low-grade lesion. Other type of juxtacortical osteosarcoma is called periosteal osteosarcoma, which is basically a chondroblastic type of surface osteosarcoma. This is a tumor of intermediate grade or considered to be grade 2. There's a suboptimal response to chemotherapy because they contain a lot of cartilage, but they are inherently of good prognosis. They have a survival rate that approximates 90% by themselves. They characteristically involve the diaphyseal portion of long bones, very characteristically the tibia, and they can actually wrap around the bone circumferentially, which is something that is commonly seen. But you can also see the different patterns of bone formation and some degree of periosteal reaction as well as Kaplan's triangle. Telangiectatic osteosarcoma is a type of osteosarcoma that is predominantly lytic. You can see sometimes very little, if any, matrix formation. On MRI, they will have a heterogeneous bright signal because they contain a lot of blood and fluid within them because there are multiple cavities filled with blood. That's how these tumors basically grossly appear. And on MRI, sometimes we can see that fluid, and at times it can form what is known as fluid levels, like we can see it here, fluid levels. The characteristic feature of telangiectatic osteosarcoma are these large vascular-like spaces that contain tons of blood in them, and then the septa are very slender but cellular and contain highly atypical cells, which have all the features of malignancy, a lot of mitosis, and sometimes very focally, you'll be able to find woven bone formation by the tumor cells. The main differential diagnosis of telangiectatic osteosarcoma will be aneurysmal bone cysts because they can look like similar histologically and radiographically and on gross appearance, but histologically you will be able to see that there's definitely features of frank malignancy and aplasia within the cells. So always go high power on anything that would look like an ABC to you and make sure that you don't miss these cells because telangiectatic osteosarcoma is a full high-grade tumor. Small cell osteosarcoma is rare, also has a predilection for a little older age group, but it can be seen combined with all the components of a conventional osteosarcoma, and they do not form a lot of woven bones. So sometimes a lot of sampling is necessary in order to find an area where you will see woven bone formation by small round blue cells that have almost the size of a lymphocyte, or sometimes can be confused with a Ewing sarcoma if you get a biopsy of the round cell component without the woven bone formation. To make matters worse, CD99 can be positive, Fly1 is negative. There's no AWSR1 gene rearrangement, and that's the most important part. Even though there has been rare case reports of AWSR1 rearranged small cell osteosarcomas, we still have some debate about that. SADB2 can be helpful because it is positive in small cell osteosarcoma, and they're considered to have a slightly poorer prognosis than conventional osteosarcoma. And to finalize, we have the high-grade surface, which is a tumor that arises on the surface of the bone, no involvement of the medullary cavity, and on biopsy would have all of the features of a conventional high-grade osteosarcoma. I think we're going to stop right here because there's no time for more. We're going to continue with the bone cysts on the next section. And now I am open for any questions. Thank you very much.
So, Dr. Garcia, if you want to continue and finish, I think you're most welcome to.
Well, if that's okay, I will go ahead. Okay. So briefly, let's go over the bone cysts. We have unicameral bone cysts or simple bone cysts. These are intramedullary cavities or cystic cavities that are filled with clear fluid, and sometimes pseudosanguinous because they may get contaminated, but naturally what they contain is clear fluid, not blood, and they're lined by a very thin fibrous membrane. These lesions are common in young individuals, usually children and adolescents. They occur in the metaphysis of the long bones. The proximal humerus is one favorite site. They will have very well circumscribed margins, and sometimes there can be a pathological fracture, and a fragment of the cortex can fall within the cavity, giving you what is known as the fallen fragment sign, or the fallen leaf sign, which is very commonly seen in these lesions. The pathogenesis is unknown. They're probably linked to trauma or bone infarct. They're more common in males. In general, most of the lesions are more commonly, bone lesions are common in males with a few exceptions. And the treatment for these lesions is curettage and bone packing, or sometimes with intralesional steroid injections. The recurrence rate is approximately 20%. And grossly, basically what they look like is like a hollow cavity within the bone, and the lining of this cavity is usually very scant fibrous tissue. So we seldom see a resection like this. Most of the times what we get is the curettage material. It is important. It's usually very scanty, and it is important to submit as much as we can of that material, if not all of it, so we can see the characteristic features of the lesion. Like I said, most of the lesions occur in the proximal humerus, proximal femur, but they can occur mostly in the long bones and sometimes in the axial skeleton, most commonly in the first and second decades of life. Here's another example of a fallen fragment sign, where we can see the pathological fracture with a piece of bone, of cortical bone within the lesion. But sometimes that doesn't necessarily occur. We have an example here. We have a very well circumscribed loosened lesion with very little expansion of the bone and a little bit of sclerosis at the periphery, which on MRI shows a single cavity, which is on fluid sensitive sequences shows a very bright signal, meaning that the cavity is filled with fluid, and it's only one cavity. The histology of simple bone cysts is very characteristic. It's basically a very thin fibrous membrane, which is most of the times hypocellular, with variable amounts of reactive woven bone. And basically, you can see a little bit of blood, but that is contamination from the curettage. Again, here, very slender fibrous membranes or fibrous septa with focal woven bone formation, and this feature is very helpful sometimes. We see significant amount of this cloudy pink material that looks like fibrin. We call it fibrin coagulum-like material, and that is very characteristic of simple bone cysts, but we have seen it rarely also in aneurysmal bone cysts. Which is the main differential diagnosis for simple bone cysts? Aneurysmal bone cyst is actually a tumor, is a benign and rapidly expansile, locally destructive multiloculated lesion. Very often you will see that there is significant expansion of the bone, but often the cortex is preserved. It tends to have a very trabeculated type of appearance because it's multiloculated, and it may be primary, as like a primary lesion, or often secondary, associated to other conditions. So aneurysmal bone cyst has been reported in association with giant cell tumor, chondroblastoma, osteoblastoma, non-ossifying fibroma, fibro-osseous, and Osteosarcoma, which are the most common entities, but we practically have seen it with any type of primary bone tumor. So it's always important to sample the tissue very extensively when we get a sample from something that is called ABC, to make sure that we don't miss a precursor lesion. The pathogenesis of ABC it was always thought to be, it was like a reactive condition, probably secondary to vascular malformation, but it has been determined now that there is a specific rearrangement of the gene called USP6, usually in the form of a translocation 16-17, where USP6 is in approximation with GDH11, and this is now supporting that ABC is a tumor. It is important to remember also that USP6 is not exclusive to aneurysmal bone cysts, but it also has been reported in other conditions like myositis ossificans, nodular fasciitis, and also in what used to be called giant cell reparative granuloma, which is now called small giant cell lesions of the small bones. So all of these conditions also share a rearrangement of USP6 and probably represent a continuum, a morphological continuum of a similar condition. USP6 now is used almost on every case because it is important to determine whether the lesion is primary or secondary. So USP6 will be rearranged in primary ABC, but not in secondary ABC. So they can occur in the spine, the axial skeleton, also the femur, or other long bones of the body. They have been also reported in the craniofacial bones less often. And it's a lesion that is usually seen in the second decade of life, but it can be quite broad. When resected, they show basically like a honeycomb appearance. They have a lot of cavities that are filled with blood, not with clear fluid. Sometimes you cannot see cavitation or actually septation very clearly, but just one single lytic lesion, like in this particular case, on a skeletally immature individual, or at least the growth plates are still partially open. Here we see some insinuation of a trabeculation, but an MRI is where you can really appreciate the multiloculation and the presence of fluid levels. You can see that these flat lines of brightness that represent the fluid as it sediments and the bloody fluid when it sediments as you change the patient's position. The histology of aneurysmal bone cysts is basically moderately cellular fibrous septa. These are more cellular than the ones that I showed you on simple bone cysts. And there is a variable amount of osteoclast type giant cells, which can be seen also in simple bone cysts, but they're not as abundant, and also the presence of reactive woven bone. So these are all features of that are characteristic of an aneurysmal bone cyst. Some lesions can have solid areas, and others can be completely solid. So there is such a thing called as solid ABC, which are somewhat contradictory. But again, what you like to see is basically these vascular-like spaces, because they're not lined by endothelial cells. They are not. And then you have abundant blood, reactive woven bone, and osteoclast type giant cells. This is something very funny, which some people describe as suicide cells. Basically, so you sometimes see giant cells that are jumping off into the abyss, and that is something that has been described often on ABC. Reactive woven bone is often seen, and one feature that has been overemphasized is the presence of this very specific type of mineralization of the matrix, which is referred to as blue bone, which is not pathognomonic, but very reassuring when you're dealing with a lesion that has all of the features of an aneurysmal bone cyst. But blue bone can be seen in other conditions, so it's not specific. There have been exoskeletal variants of ABC, basically a soft tissue tumor that has all of these features, and it's USP6 rearranged. So there's definitely soft tissue ABC. And it's, again, another contradiction, because it's an aneurysmal bone cyst of the soft tissue. But they do occur. And the treatment of bone primary ABC will be excision or curettage. They have a very variable but high recurrence rate. So a lot of the lesions that are curated, primary ones, they can come back very often. So that's something that needs to be taken into consideration. And the main differential diagnosis, like I mentioned before, will be with the telangiectatic osteosarcoma, which has exactly the same kind of like architectural pattern, but the cells will be definitely, frankly, malignant. And if you look at the spindle cells of ABC, by the way, the spindle cells are the ones that carry the USP6 rearrangement. Those cells will be cytologically bland. Giant cell tumor may enter the differential diagnosis mainly on a solid ABC, but giant cell tumor has a very different characteristic appearance radiographically. And of course, the USP6 rearrangement will not be present in giant cell tumor. They carry something different, which we will discuss later. And of course, simple bone cyst has a totally different histological as well as radiographic pattern. It is always important to exclude underlying lesions because remember, about half of ABCs are secondary. And just to finalize, we're just going to discuss fibro-osseous lesions real quick. We have fibrous dysplasia. This is a lesion that everybody is very familiar with. The benign fibro-osseous lesions that commonly affect the gnathic bones, meaning the craniofacial bones, and also the long bones. And in the appendicular skeleton, they can actually be quite extensive and produce significant remodeling of the bone. So there can be some degree of fusiform expansion of the bone, but never with the aggressive feature of endosteal scalloping, cortical breakthrough, pathological fractures may occur. And they characteristically have this classic ground glass or smoky appearance of or opacification of the medullary cavity on X-ray. Experts do not agree on whether this is a reactive process, is a plastic process. What is known right now is that this is a sort of like a malformative process that is due to a gene mutation that is that involves the GNAS complex. There's a constitutive activation of adenylate cyclase and high levels of cyclic AMP, which leads to endocrine hyperfunction and overproduction of disorganized fibrotic bone matrix. So basically, not a neoplasm, but a condition that is due to a gene mutation. In the gnathic bones, it can produce very gross deformities and even like cherubism, which is bilateral enlargement of the maxilla and mandible, and produces this particular phenotype. And in long bones, like I said, they can produce significant expansion because there's a slow-growing lesion that allows for remodeling of the bone. And they can be monostotic or involve only one bone, or polyostotic, like in this case, where they can involve multiple bones. Sometimes it's only one limb or multiple limbs, or monomilic or polymilic. And characteristically, especially in the polyostotic type, there might be very gross deformities, and a lot of times you can lead to what is known as the shepherd's crook deformity, which is seen here. Actually, this patient required some orthopedic intervention because of the must have been deformity and pathological fracture, which is commonly seen in these cases. And like I mentioned before, the characteristic radiographic pattern is that of a ground glass appearance. It's not sclerotic enough to be looking like cartilage or like an osteosarcoma. And here we have the distribution. The femur is actually the most commonly affected bone, followed by the tibia and the craniofacial bones, but it can occur practically anywhere, except for the spine. The ribs are also very commonly affected. Most of the cases are diagnosed before age 30, and fibrous dysplasia is one of the lesions that is slightly more common in females. The gross appearance of fibrous dysplasia is like an ivory-like type of bone formation, but this is brittle. This bone is not structurally stable, and fractures can occur very easily. And the histological features is that of a basically moderately cellular, cytologically bland fibrous stroma with curvilinear slender trabeculae of woven bone. And it is overemphasized that these are naked trabecula because they do not show significant osteoblastic lining because the bone is being formed directly from the fibrous stroma. You may see a variable number of osteoclasts because these trabecula are being remodeled, and sometimes there can be some cartilaginous differentiation. Here we see how the bone matrix is being kind of like added to this pre-existing trabecula on the surface of the bone. And they're not a very prominent osteoblast. But sometimes one can see focal osteoblast lining on the surface of the bone. Here's one other example of polyostotic fibrous dysplasia with cartilaginous differentiation. We can see the ring and arc pattern here, and sometimes these lesions can be confused with a cartilaginous tumor in a monostotic form. But when you see the histology, you will be able to see the classic features of a fibrous dysplasia and mixed with benign hyaline cartilage islands. That has really no impact on the behavior of the lesion. So the main differential diagnosis of fibrous dysplasia is well differentiated intraosseous osteosarcoma, so-called low-grade central osteosarcoma, and basically one of the things that is helpful in this particular setting is lack of amplification of MDM2. If you have a biopsy or something that you're not really sure if it's either one or the other, the next available and easiest thing to do is FISH analysis for MDM2. Because gene-as mutations are a little bit more complex, more time-consuming, and a lot more expensive. So this is our practical way to deal with this. Is besides establishing good clinical and radiological correlation, is excluding MDM2 amplification, and that will establish the differential. And the other condition that is enters the differential diagnosis is a condition known as osteofibrous dysplasia. We're going to discuss it next. This lesion has a very peculiar location in the bone, but the histomorphology is very similar, except that the osteoblastic lining is or rimming is extremely conspicuous. Fibrous dysplasia is treated with segmental resection or curettage. Orthopedic interventions are required often when there is significant deformity. He is one monostotic form with a shepherd's crook deformity. And it's important to remember that very rarely you will see a malignant transformation, usually into an osteosarcoma. Curvilinear trabecular woven bone in a cytologically bland fibrous stroma with inconspicuous osteoblastic lining and occasional osteoclast type channel cells. Polystotic fibrous dysplasia is associated to two main syndromes. In McCune-Albright syndrome, you can see precocious puberty most commonly as part of an endocrine hyperfunction, but it could be hyperparathyroidism, hyperpituitarism, and any other type of endocrine hyperfunction. And also, it's associated with cafe au lait spots. So that's what comprises McCune-Albright syndrome. In Massa-Broad syndrome, you can have polystotic fibrous dysplasia associated to the intramuscular myxomas. Here's a distal tumor with something in the medullary cavity, which is basically what represents the fibrous dysplasia, and you have a very bright lesion in the muscle, well circumscribed, which is basically an intramuscular myxoma. This comprises of Massa-Broad syndrome. And interestingly enough, the gene-as mutation is found in the bone lesions, but it's also found in the myxomas, not only on the ones that are associated to polystotic fibrous dysplasia, but also sporadic myxomas. Intramuscular myxomas have gene-as mutations, so that is important to remember. Osteofibrous dysplasia, on the contrary, is a cortical-based lesion that almost exclusively occurs in the mid-shaft of the tibia or the fibula. So this is a very uncommon location and radiographic appearance for a fibrous dysplasia. So just by knowing where the lesion is, in the radiographic appearance, you can almost for certain exclude that it is fibrous dysplasia. It's histologically very similar, but osteoblastic lining or rimming is very prominent. And this is a lesion that is more common in very young children and adolescents, very rare after the age of 15, and it lacks progression after skeletal maturity is reached. So most of these lesions are basically radiographically watched rather than operated on, unless there is a risk for pathological fracture. Spontaneous regression has been reported in this condition. So practically, all of the lesions do occur in this location. So if you have something that looks like fibrous dysplasia elsewhere, it is fibrous dysplasia. But in this location, then you have a problem. Again, very young age group, intracortical, multiple lucencies with surrounding sclerosis. That is characteristic of osteofibrous dysplasia. And this is the common location, the mid-shaft of the tibia or the fibula. Gene-as mutations are absent in osteofibrous dysplasia, but like I said before, this is not a very easy test to perform. Very seldom will need to do it. And trisomy 7, 8, and 12 have been detected in osteofibrous dysplasia. And this is an interesting finding because it's also something that has been found in a somewhat related lesion that occurs in this same location, which is known as adamantinoma. They also carry trisomies of 7, 8, and 12, which probably demonstrate a relationship between the two lesions. So the histomorphology of osteofibrous dysplasia is very similar to fibrous dysplasia, moderately cellular fibrostroma with irregular trabecular woven bone. But here you can, even from the medium to low power, you can see how prominent the osteoblasts on the surface of the trabeculum trabecula are. So, so this is definitely a feature that helps us distinguish osteofibrous dysplasia from fibrous dysplasia. But I have to say that rarely we see focal osteoblastic rimming in fibrous dysplasia, so something that is not absolutely pathognomonic, especially in a small biopsy. So establishing the clinical and radiological correlation, the location of the lesion, the radiographic appearance, almost practically will help us establish the diagnosis. Interestingly, if you do a cytokeratin stain on a patient with sample with osteofibrous dysplasia, we will see focal positivity, isolated cells, never clusters, never nests, never glandular structures, always individual scattered cells. And that is seen very often, but is and it's helpful when we want to prove the diagnosis. But in the main differential diagnosis between osteofibrous dysplasia and adamantinoma, which is a malignant tumor that tends to occur in the same location, it may have a fibro-osseous appearance, but it does contain epithelial differentiation. So you will see actual nests and clusters of epithelial cells, not just isolated cells like we see here in osteofibrous dysplasia. So the differential diagnosis of fibrous dysplasia has already been mentioned multiple times, and adamantinoma, like I mentioned, is a tumor with true clusters of epithelial cells, and it's an intramedullary tumor. It's larger and it's more aggressive. Close follow-up is advised since many lesions are self-limited and do not progress or regress spontaneously. Recurrences occur after excision often, and biopsies are seldom necessary. A lot of these lesions are just followed up radiographically. Only treated cases that have fractures or deformities. And progression to adamantinoma has been documented. So there is an incompletely understood relationship between the two, but it is definitely thought that osteofibrous dysplasia may be a precursor of adamantinoma, but not all the cases will progress into this condition. And I think with that, we're going to close today's lecture. Thank you very much, and I'm open now for questions.
Thank you, Dr. Garcia, for this excellent discussion on so many different bone-forming tumors, and I'm sure our viewers have found them very useful. There are quite a lot of questions online. Let me try my best to at least address a few of them.
Okay.
Here is a question from one of our viewers from Egypt. The question is, I want to ask about osteosarcoma chondroblastic variant. When biopsy revealed mainly chondroid areas, and there is suspicion of being also chondrosarcoma. So what's the optimal action as the treatment will be different? Should we suggest a deeper or open biopsy? So because sometimes the surgeon resists open biopsy, saying it will hinder limb salvage in cases of osteosarcoma.
Okay. So there are two things that you have to, in which you can actually address this issue. The first thing is, again, clinical radiological correlation. The first thing you need to think about is that chondroblastic osteosarcoma is a lesion of young individuals, and chondrosarcoma is a lesion of older individuals. This is not an absolute criterion, but you more or less start thinking about how likely it would be a chondrosarcoma if this patient is, let's say, 20 years old or less. Now, second, the presence of woven bone in chondroblastic osteosarcoma can be absent in a small biopsy, so there is a molecular way of telling that it is chondrosarcoma or not. So cartilaginous tumors, and we're going to discuss that on our subsequent lecture. The classic ones are positive for IDH1, that's isocitrate dehydrogenase 1, and less commonly IDH2 mutations. So nowadays, molecularly, we can do that in tumors and determine if the there is mutation of IDH1 or 2 in this cartilaginous tumor-looking lesion, then it is most likely a chondrosarcoma. If it is negative, it will be a chondroblastic osteosarcoma. But I think before doing something like that, which probably can be very costly, I will probably establish a very good radiological correlation. If you have a tumor that at least histologically shows evidence of, radiographically shows evidence of sclerosis or bone formation, and not just a cartilaginous appearance, then you will have to say, okay, this is a malignant chondroid forming neoplasm. And in a comment, you probably will say, based on the radiographic appearance and the age of the patient, this most likely represents a chondroblastic osteosarcoma, even though a chondrosarcoma cannot be excluded. I think that doing the IDH1 and 2 here in the United States is something that we can do in certain centers as specialized as our neighbors across the street in Memorial Sloan Kettering. This can be done either by immunohistochemistry or even more sophisticated ways, like gene sequencing or PCR, but definitely a very helpful tool in establishing or confirming the diagnosis.
So there's another question. The question is how to exclude chondroblastoma in aneurysmal bone cyst with pericellular blue bone.
Okay. The histomorphology of the cells of chondroblastoma is very characteristic, and I have to say, what we see in chondroblastoma is actually pericellular mineralization. So you have strings of calcium around each cell, but the cells are so, let's say, so epithelioid looking that you will see just this very chicken wire pattern of mineralization around the cells. But the blue bone that is seen in ABC and is also seen, for example, in Nora's lesion, which is bizarre parosteal osteochondromatous proliferation, it doesn't really surround these histiocytoid cells or epithelioid cells. It's more like around smaller cells, or sometimes it just doesn't have any cells at all. It just looks like bone matrix that instead of being pink to purple, it looks dramatically blue. But I think that if you want to make the distinction, is basically on the cells and not on the matrix itself.
Right. So another question that I found online is, should we use atypical sclerotic osteoblastic neoplasm in routine surgical pathology practice? How treating clinicians interpreted this term in patient management?
This probably doesn't help them at all. Because this actually is something that might be very frustrating to a clinician when we call something, we do it a lot of times. We call something unclassified atypical cartilaginous tumor. It's something that sometimes we are obligated to use. At least what we say is low grade. We try to say that is low grade because that's probably the only thing that it matters to them. Is the lesion low grade or is the lesion high grade? So I seldom will use the term atypical osteoblastic lesion. It is more often used in cartilaginous lesion because I think for osteoblastic lesion, it's easier to establish the differential diagnosis when you establish a good radiological correlation and use molecular whenever you need it. I don't know what the specific case scenario is where they will use such a diagnosis, but I will try to avoid it as much as possible. We have used very seldom the use of the term atypical cartilaginous lesion because sometimes you really can't tell low-grade chondrosarcoma from an enchondroma. But in osteoblastic lesions, for example, something if it's osteoblastic and atypical, probably your differential will be between an osteoblastoma and an osteosarcoma. And that the only way to tell them apart is by looking at the edge of the lesion, which you cannot evaluate on a biopsy. If the lesion is permeative at the periphery, then it is a malignant. It is an osteosarcoma. And if it's not, it's probably an osteoblastoma. So I think that using good radiological correlation, you can probably tell that it is not malignant. But if you have no other choice, I think that there are certain things that you can do molecularly. Let's say if you have such a predicament, is this an osteoblastoma or is this an osteosarcoma? I haven't been yet in this situation, but if I needed to do something, I would try probably FOS and FOSB mutation. If it is positive, it is likely to be an osteoblastoma because that is it has been proven to be negative in osteosarcoma and even in the osteoblastoma-like variant. So again, like nowadays we have so many methods of trying to confirm or exclude conditions that we try as much as possible not to use those terms, those descriptive diagnoses, because a lot of times they're totally useless to the clinician. And our main purpose is to give them an answer, whether the lesion is benign or malignant, whether the lesion is low grade and high grade, and how they're going to approach the treatment of the patient.
Another question is, do you use alkaline phosphatase for diagnosis of osteosarcoma in any situation, maybe in patients with suspected extraskeletal ones? Do you use that?
No, not at all. No, we don't even have a stain for that. I think that at this day and age, I would use SATB2, SATB2, as an osteoblastic marker with care, with a lot of care, because in my experience, I have seen things that are completely not osteosarcoma or osteoblastoma or anything related to an osteoblast that are SATB2 positive. Remember that SATB2 was originally described in colon. So there is the control for SATB2 is colonic epithelium. But in terms of tumors, I have seen lesions of bone that are SATB2 positive that are not an osteosarcoma. So in appropriate context, where you see something that looks like an osteosarcoma, has all the histological features of an osteosarcoma, clinical and radiographical features as well, then doing a SATB2 will be very helpful in confirming the true osteoblastic nature of those cells. But I don't use alkaline phosphatase at all. That probably was something that was used decades ago, but not anymore.
Another question is, can you be confident when grading osteosarcoma as low grade on a small biopsy because the tumors can be so heterogeneous?
Yeah, absolutely not. I apply that to practically any type of tumor, cartilaginous tumors as well. If on a small biopsy, you can always say low grade osteosarcoma, see comment. And then in the comment you say high grade areas cannot be excluded due to sampling. So it happens a lot, and even in certain instances where it could be catastrophe, which is in dedifferentiated chondrosarcoma. Sometimes because this is a biphasic tumor, if you get in the biopsy, you're going to get only a low grade cartilaginous lesion, when indeed inside you have a monster, which is the dedifferentiated component, which is basically going to kill the patient. So it is always advisable to, in a biopsy, clarify that sampling error may be a factor, and that other higher grade areas cannot be excluded based on the limitations of the biopsy.
So I think one last question is, does percentage necrosis in a resection with preoperative chemo really reproducible in your practice? 90% necrosis involves myxoid and reactive appearing areas too. Is that right?
Yeah, yeah. I mean, anything that if you're looking at a sample, a mapping of the tumor, and anything that grossly and radiographically look like that tumor, that then on histology does not show viable tumor cells is considered to be a therapy effect. But there's one thing that I didn't discuss because of lack of time, but you know that a lot of the necrosis that you see in a tumor can be spontaneous, can be present there pre-treatment. So that's why the 90% cutoff has been chosen, because it is estimated that up to 90% of the necrosis that you see in the tumor is spontaneous, is not induced by the chemotherapy. And actually, all of these large studies are the ones that have demonstrated that anything more than 90 can be considered to be optimal. Some other people are trying to push that even forward into 95% and so on. But of course, these are all very subjective criteria, and you can actually show a case to 7 pathologies and they will give you a different percentage, because it's a very subjective, and it's also depends a lot on the eye of the beholder. But again, yes, the necrosis first can be basically not related to the chemotherapy, and second, areas that look myxoid, hyalinized, inflamed, and do not show any clear-cut tumor cells are considered to be necrotic areas. Another thing that is also very helpful is when you see what we call turtle shells, which is basically residual calcified matrix without cells. And that tells you that you definitely are in the middle of the tumor. And what you're looking at is a section of tumor that has no viable cells. So those are also things that histologically are helpful.
Thanks a lot, Dr. Garcia. There are a lot more questions. I'm so sorry that we won't be able to address all of those. So please bear with us. And Dr. Garcia, you would be so happy to know that we had so many viewers from different countries. Like we had several hundred viewers from across the world, and more than 30 countries have joined. I would just name a few, including viewers from Bosnia, Somalia, Ecuador, Myanmar, Bolivia. Of course, there were viewers from US as well, and Oman, just to name a few. Thank you all our viewers for joining in. And just to let you know that we had another lecture coming up on May 5th, that is next Tuesday. That would be on practical update on urothelial neoplasms by Dr. Anil Parwani from Ohio State University. And in fact, Dr. Garcia will also continue his bone lecture series. So the second lecture will be on June 5th. That would be on cartilage forming tumors. And as always, if you like our lectures, please make sure to subscribe to our YouTube channel, that is Patcast. And in fact, you can click on the bell that is next to it so that you will remain notified. And also, if you follow our Facebook page, that is by the same name, you will also stay notified about the upcoming lectures. So thank you all, everyone, and hope you are all staying safe. And thank you, Dr. Garcia.
If I may to say a last word, first, thank you again for having me in this platform. If there are more questions that we cannot answer due to lack of time, you can feel free to write to me at garciar@hss.edu. That is my email, and I'll be happy to answer the questions if I know the answers. If not, I'll look them up for you. So again, GARCIAR at hss.edu. garciar@hss.edu. Thank you very much.